Hello, everyone. This is Eric Glazer with my producer and co-host today, Gene Ware. Welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform our audience, but also unearth successes, bright spots at health plans, hospitals, and other healthcare organizations around the country. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime.
And hi, everyone. I'm Gene Ware, producer of today's episode. I'm here with a quick PSA. Now, if you have not subscribed to this podcast, please stop what you're doing right now. Click on your favorite podcast app and type in Bright Spots in Healthcare. Please subscribe and rate us with 5 stars. We are presently averaging at 4.8, and the more ratings and subscribers, the more of your peers can find the show and get this great information. Now, the more people who find the show, the more we can get to 5-star ratings. And on that note, our topic today is, can your social care strategy get you to 5 stars? We have an all-star Who's Who panel in front of you today. They are Dr. Andre Bliss, who is Director of Medicare Stars at UPMC Health Plan. We have Mallory Mueller, Director of Quality Health Integration at Network Health. We have Cherie Shortridge, Senior Advisor at Healthmine, and Libby, President of Benelynk. As usual, to save time, we're bypassing reading their full bios, but our producer, senior producer, Cherie Keels, is posting them in the show chat, and we'll add them to the description on your podcast app as well.
Good work. That was a nice transition with the stars, by the way. I noticed that. Our prime today and sponsor for today's episode, they are our friends at Benelynk. Benelynk, if you haven't heard them on the show before, they've been part of our partnership program for a couple of years now. They are a national provider of social care solutions for Medicare Advantage and managed Medicaid health plans. They serve plans and their members by creating a interesting and pragmatic approach to innovative technology and human-human connection to provide assistance to your members' needs to get all the benefits that they deserve and enable you to reach those 4 and 5-star ratings that you work so hard to get to. I want to start the show off. We're actually going to do something I usually don't do, but we're going to actually start with Benelynk. Libby is the president of Benelynk, because I want to start with the Health Equity Index, which is relatively new, but everyone's been working through this context. And I want to, Sean, if you don't mind, let's talk about the impact that the Health Equity Index is making on health plans' approach to product development and the overall approach to quality. Because as we know, the index reward will take effect for 2027 star ratings, but already measuring performance in 2024 and 25. So essentially, it's started already. Can you provide just an industry overview of how this is changing how health plans do business?
Sure, happy to. And thanks for having me on, Eric and Gene. And thanks everyone for spending a little bit of your Thursday morning and afternoon with us. So about the Health Equity Index, we all know that it's replacing the reward factor measuring performance, as Eric said, in 2024 and beyond. And we all know that right now the subject population is those who have a, quote, social risk factor. And effectively, those in the denominator are duals, members with the low income subsidy, and those whose OREC is disability. And the index is a measurement of disparities in providing healthcare to this population. I think one thing that really stands out is the definition of that subject population is that it was really clearly crafted to start with the easiest to define objective population using these measurements that CMS already had, who are the duals, who are the LIS, and who are the disabled population, right? So I think that was a logical place to start. But I think we're already seeing the indicators that this idea of who has a social risk factor is going to go beyond that, right? And that means that there needs to be a way to identify this population that quickly we're going to be looking for that's not just looking at the duals, the LIS, and the disabled population. So it raises the question of sort of what happens next and what should forward-looking progressive plans be doing in terms of thinking about social risk factors and this really important health equity index that we all know we're we're working towards. So to skate toward where the puck is going, I definitely see there's a bunch of different approaches that we're seeing implemented in terms of understanding that population that could have a social risk factor. One national plan has implemented a program where whenever a member flags a social care need, that member is then being referred over for social care assessment. Most importantly, importantly, using one of the screening instruments that meet the requirements from CMS and NCQA. And that way, future social risk factors and SRF populations are objectively being categorized using the relevant code sets. And the plan can already now be starting to look at differences in care outcomes and in disparities. So it's about not just understanding what are the populations that are defined now within SRF, which is pretty narrow and clearly defined, but also where are we going? What's the next population? What's the wider population that the Health Equity Index is being intended to address? And ultimately, that's really about all the members that have social risk factors.
Yeah, thanks for that, Sean. That was a really good stage set. Before we move on, and Jean's kind of ready to shoot with another question, Sean, I think maybe, and I don't want you to panic here, your mic's causing a little bit of background noise. I did some QA. I think it's yours, but I'm not positive. And so I don't know if you're accessing your regular mic, because usually I don't hear that on your side. So while we're moving on with the interviews, take a look on your end, but definitely mute while you're doing that, because we were definitely getting a little bit of background noise. Not that we couldn't hear you, but I think it'll affect.
I heard that. I'll switch over to a different mic.
Okay.
Awesome. Well, guys, hey, now that we have that great overview, I think it makes sense to kind of double click on some real world examples, dare I say bright spots. So Mallory Mueller is the Director of Quality Health Integration at Network Health, and they only have 5 and 4.5 star products. Hey, Mallory, how is the Health Equity Index driving Network Health's approach to MA and dual members?
Thanks, Jean. Yes, I think, Sean, you teed that up beautifully for me in terms of, everyone needs to be reading the tea leaves on kind of where do we go next. So I don't think you get to be a 5-star plan or maintain a 5-star without looking ahead and trying to plan for the future. So at Network Health, we're really building a comprehensive approach to addressing social determinants of health. So I think we've all heard the statistics, right, that social needs are really driving 80% of healthcare costs and health outcomes. So we feel like that is really the foundation for our Health Equity Index strategy and how we address some of the disparities in care. So we have developed an internal process to really prioritize our population and look at how do we gather social determinants of health data. So we've formally adopted one of the approved tools that the HEDIS social needs screening measure allows us to utilize. So we've adopted the American Academy of Family Physicians assessment tool, and we have our care management staff doing outreach and collecting data using that tool. In addition to that, we've also partnered with a vendor partner, Benelynk, to do some outreach on our behalf to gather social determinants of health data. We realized that really gathering the data is step one. We've already started looking at step 2, which is really taking a step back and analyzing that data. Having the social determinants of health data is great, but you really need to take a look and analyze and determine where there are gaps in your current benefits. Are there additional supplemental benefits based on the social determinants of health needs of your membership that could help with addressing those things?
Eric, you're muted.
I knew that. So I want to stay with the theme of examples. Before I do, one of the biggest healthcare conferences of the year is called Health, HLTH. Some of you may know it. I'm not affiliated with that meeting in any way, but I will be at that meeting in Las Vegas on October 8th, 9th, and 10th. I think it runs the 7th through the 11th. But 8th, 9th, and 10th will be the meet at the time I'm there. I would love to meet with any of you in the audience that want to connect, just to say hi or even talk about programming or anything that you want around healthcare. So I'm going to ask the team to put up a poll. And those of you who want to connect one-on-one at Health, love to see you there. And I'll reach out electronically following the meeting for anyone that writes yes. And if you're going to be out there. No obligation, no obligation. So let's talk about Health Equity Index and bring in Dr. Andre Bliss. Again, he's the Director of Medicare Stars at UPMC Health Plan. Andre, how is your plan thinking about product development with HEI in mind?
Yeah, thanks for the question. We're trying to adapt, what our different products and things look like, given the new HEI index and how it's, going to take the place of the new or the traditional reward factor becoming the new reward factor. So, our SRF population is really carved out, right? We have our own, standalone SNP plan that we've moved a lot of our members into. So it doesn't, we don't have a lot of SRF members that are reflective in our HMO and PPO contracts there. So we're trying to understand ways in how we can potentially smartly increase that population under those particular contracts. And then also utilize the information and knowledge that we know in having a really high performing SNP plan, how we can align some of the products and shift the products that we want under those particular contracts as well, so we can have high quality ratings with that particular group as well. So we're really early stages in that. It's just things we're trying to do some research on, seeing if that's a feasible way for us to kind of move and shift populations. At the end of the day, we know we need to improve quality amongst this population. That's like full stop. But there's other things that we're trying to do from a strategy standpoint that can help us there. So,
thanks, Andre. So it sounds like, just in summary, you're no commitments yet, but you are looking into a strategy of maybe carving out or embedding or including within your current HMO and PPO products / contracts SNP populations that normally or historically you haven't done.
Correct. And in that, making sure that there are the right segmentations even across our state, right? Across the state of Pennsylvania, right? So just ensuring that, in our urban populations, right, that the type of benefits that are needed, for that population are reflective in our present amongst that plan benefit package that we offer in that area, maybe differing for some of our rural communities, and just making sure we have that alignment. I think the analysis and research that we all would need to do from a health plan standpoint, and understanding what benefits and things we have, also what benefits that we have that maybe are underutilized, and tying that connection into quality performance, right? If we can tie that connection into, like, members that typically use this benefit have higher quality ratings amongst this group of measures, right? Let's do some more promotion and targeted interventions and targeted outreach and promote that particular benefit. Or maybe it's a benefit we don't have yet. How can we get that in our suite of benefits that we offer for our population? So those are the things that those are the questions we're asking ourselves, and the research we're trying to conduct right now.
Thanks, Andre. I see some of these questions coming in. We're going to be tight on time. There's at least one question here that fits really well within our payer and provider collaboration segment. So I'm going to hold off. I'm going to try to mix that in. Little announcement, Gene. So we'll try to fit that in. Let me, real quick, folks, before we move on, tell you quickly a little bit more about our partner in crime today, Benelynk, who I mentioned serve health plans and other risk-bearing organizations and their members by creating this human-human connection enabled by leading edge technology to provide assistance, a personalized assistance to your members' needs as it relates to benefits, and getting them activated and engaged in the services they have coming to them that will enable them to be happier, healthier, and of course, contribute to your positive bottom line as you reach 4 and 5 stars or maintain that level. By employing one dynamic conversation that flows organically by way of technology to that human being, they are able to meet social determinant of health challenges of your members and build a stronger ongoing connection with that member, human to human, again, supported by that innovative technology. Their services are customized by specific geography and provide services to the members with specific information around that geography that allow them to get their benefits, overcome social driver challenges, all within, a short drive or walk from where they live. Their mission is to improve the lives and positively impact social determinants of health barriers by providing all of you with the information you need and with the people and the expertise and the advocacy that your members deserve. So you can check them out more at Benelynk.com. If you're thinking about programs involving a company like Benelynk or just you're trying to build your own, they have a really interesting paper they wrote on generating ROI through integrated Medicare Advantage SDOH advocacy, which I highly recommend you look if you're trying to build a business case. It's not just about Benelynk, it's about how to build a business case. They talk about SDOH identification, ICD-10 documentation, and customization of care. And the report has all kinds of numbers that you will find helpful as you think about your business case in upping your game around social drivers. So I'm going to offer you up that piece rather than search for it on the web and go through a gate and have to put in your name and number and everything else. I'll email it to you after the show if you want it. Like I said, it's jam-packed with information. It is branded with Benelynk. It's technically called a white paper, but I would suggest that there's information in there that is agnostic to whatever you're trying to do within your role around social drivers. Gene, now you're on mute.
Well, now we're even. Hey, Eric, I'd like to bring it back to Mallory if I can. Mallory, can you provide a specific example of product enhancement at Network Health that's driving you towards health equity?
Absolutely, yes. My example is not exactly a product enhancement, but really an innovative idea, or what we think is pretty innovative here at Network Health. So again, reading the tea leaves and knowing how important health equity and addressing social determinants of health is going to be now and into the future, we quickly brainstormed and came up with an idea leveraging our provider network. So we have created these amazing relationships with our value-based contracted providers. And it's allowed us to come up with an idea to really allow them to apply for funding. So we have what we are calling our Provider Quality Improvement Fund. And it's really a fund that Network Health has come up with to really drive some of the performance around health equity and addressing disparities. We know based on our data that our members achieve the best outcomes when the care comes directly from the provider or the provider system rather than the health plan intervening. And so how can we help them to create these quality improvement processes to really address some of the disparities? So we kicked this work off here in 2023, and we're really excited about some of the early outcomes that we're seeing. So we have 3 projects that are currently underway. We have one provider system that applied for funding to purchase a diabetic eye camera. And they're using this camera in some of their rural clinic settings and in rural Wisconsin to provide a diabetes eye exam as part of their annual wellness visit. So overall, that project is right on track to meet the metrics by the end of the year. And they're again, targeting members that are at risk for some transportation disparities and social determinants of health. We have 2 additional projects that are underway that both involve an ambulatory pharmacy team and really targeting members with diabetes and congestive heart failure. And they're using the ADI, or the Area Deprivation Index, to identify members or their patients who live in specific zip codes that we know are at greater risk for social risk factors. And so they're identifying members that have those social risk factors and providing outreach to them to talk about medication changes, to talk about lifestyle management, doing a lot of care management services and high touch outreach with the goals of reducing A1Cs for the diabetic population, as well as looking at overall medication costs. And then, of course, for our heart failure population, looking at ED visits and inpatient stays as metrics of success. As I said.
Oh, go ahead.
as I said, early outcomes are really showing some great results. So we are excited to continue this program in 2024.
So an eye initiative for folks living with diabetes and the eye cameras in the PCP offices in rural offices you're funding. You're using ADI to identify higher risk members and leveraging pharmacists to do outreach for folks who are at high risk due to social drivers with diabetes. And then you're doing a similar program for heart failure in those three areas. And it seems like early indication is worth the time and energy and money.
Correct.
Awesome.
Wow, that's super innovative and great to hear. I love bright spots like that. I want to swing over to Andre, if I can. Andre, like Mallory, you also represent a plan that has 5 and 4.5 star products, one of the best of the best. I mean, what is core to you consistently achieving such high marks?
Yeah, I mean, there's a couple of key things that we try to focus on, year in and year out, and things that we think are vital for us to maintain a high rating. One is leveraging our care managers. Our care managers do a lot. Obviously, we've been talking a lot about the health equity index. Are going to be vital and key into plans doing well related to that particular index and that shift in the star rating. But then getting their work and documentation and things to count, right? They're doing a lot of work, and sometimes it all doesn't directly count to a gap closure or what have you. But there's some innovative ways that you can get some of these things to count. It's just about connecting and collaborating with your NCQA auditor and just working through some of those details, understanding that clinical workflow and all that information that they may need and they may need to validate in order to get a lot of that information to count directly for HEDIS gap closure, because a lot of times they're doing the work already. So why not take advantage of that? So the other area, which has been huge for us, is just our member experience and customer service. We do a lot of work and strive to be ideally best in class in that area. Having one call resolution, having access for our members so they can see all their upcoming appointments. We're actually piloting something new where they can see any gaps in care that they may have from a HEDIS standpoint, right? So that they have that in an app that for those that are inclined to, love their technology, they have access to that information in somewhat real time, so they can act on it, without having to call in or see their doctor to understand what they may be missing from that standpoint. So, and then with our customer service, we have predictions around CAPS performance and things that are readily available for our customer service reps. So they have all that information available to them. If we do a targeted outreach, they have it. Maybe a member calls in and they're addressing, something that, maybe has nothing to do with a CAPS area, but we know from a predictive lens, like, hey, they may be struggling with some access issues. Let's see if we can address it. Can we help them do some direct scheduling? It's very obviously helpful that we are an IDFS, integrated delivery financial system. So we have some of those capabilities to do some direct scheduling and things to some of our primary care and specialists. So we definitely leverage that, wholeheartedly there. And then just getting access to data. So ingesting as much data as possible, whether it's from ADT feeds that we can then act on, ingesting data from, all the CCHIEs that we have available to us. Like that, the data is king. So, ingest as much data as possible. So those are kind of the pillars that we lean on.
Andre, I'm going to try to repeat those 4 pillars for everyone, make sure I get this right. So the first is sort of your care management and documentation process. And you've got these ongoing NCQA auditors that are sort of mimicking what your scores are going to be. So you're on an ongoing basis, know what's going on. That's the first pillar. The second is pillar around call resolution or one call resolution, where you're connecting with the representatives to the right information. You also have a gaps in care almost scorecard that a member viewing version of it within your app to help let the members see what your care manager or your call center representative is saying. The third that I sort of captures this live predictor scorecard, CAPS predictor scorecard, so where potentially negatively your HEDIS and CAP scores are going to come from, and then you could proactively address it. And the fourth is just your overall commitment to data ingestion. You mentioned ADT in passing. My guess, you have probably a little bit of an unfair advantage being part of a delivery system as well, but just in general, a lot of data ingestion that's not unique to just an integrated health plan delivery system. Any health plan could be doing maybe better job thinking about how to get the data and collaborate with the providers around seamless data exchange.
Yeah, exactly that. And even one, based on, that last point there, one area where we're starting to get data from is from our Department of Health Services, and they have access, at least in Allegheny County, where Pittsburgh is, we have access to members that have intellectual disabilities, and we're ingesting that information and data now. We don't have it for all the counties that we have our plans in, which is obviously across the state, but this is beyond the IDFS. Just anybody that's willing to share in data that we want to ingest all of that, and then obviously tailor our work and our plans and stuff to assisting with those members.
Great. What we're going to do, folks, for the next half of the show is we're going to divide it up into sort of 3 sections. We're going to cover member activation and engagement next. Excuse me. Then that payer provider collaboration I alluded to, and then maybe we'll summarize it with like a blueprint on how to build the program. And that's how the next 30 should go. So it's going to be jam-packed. So strap in and get your pencil or pen ready for some note taking. So activating and closing gaps for hard to reach members like duals, age-old challenge. So Sean, I'm going to bring you back in. I think what's important here is that many of the answers to questions about activation and engagement appear to be the same, right? We talk about it all the time. But I'm wondering, when you compare the answers from last year, year before, 5 years ago, if there's actually today some subtleties in what some health plans are doing that are actually better in their approach to activation and engagement, that is actually, if I could use actually one more time, that is really making an impact and improving performance of health plans. If you could sort of pull those out so everyone could see them crystal clear, maybe put them under a magnifying glass for us, that would be great.
Sure. I hope the new microphone's okay. Does it sound all right?
Yeah.
If not, I'm going to go to holding up signs like the old In Excess and Bob Dylan things, Anyways, happy to address that. We've talked a lot about sort of, the social care elements that are in quality. And one thing that I think we're starting to see really innovative plans starting to do is to look at social care, not just as a goal in and of itself, which of course it is, but also a method to engage members more broadly, right? So one innovative approach there is, as you sort of teed up there, Eric, gap closure, right? We know that the Venn diagram of members who often have gaps and members who have social care needs, that there's a lot of overlap there. So what we're seeing is that plans are sort of taking the awareness of that social care challenge and taking that opportunity to engage with a member and provide social care assistance as a mechanism to help them to close gaps outside of social care as well. So we see this one plan we're working with, we see doing this outreach where they're outreaching to the member, talking to the member about active social care needs they have. Sort of the concept we call leading with help. What's front of mind for the member? What are they most worried about? Addressing those first, meeting those challenges first, to build trust with the member, but also just to really get to the challenges that the member is most concerned with. And then at the conclusion of that relationship saying, hey, by the way, this plan is trying to conduct cancer screenings in order to close those gaps, to say, hey, you're due for a screening. Glad we were able to help you with this. Can I help to get that set up for you? Can I make a transfer over for you to be able to schedule that appointment? So what's really great about that is obviously it's an opportunity to close a gap that's really, really hard to close because you got a member that might not necessarily engage, generally speaking. You have, at the same time, you're really closing some social care challenges. You're helping to improve somebody's lives. And it's a real member-centered experience, right? So it's something that's going to be reflected in things like CAP scores, right? The member is going to feel good about the process because their primary concern was addressed in the call, as well as sort of trying to get the care that the plan knows that they need addressed.
So if I was gonna, I just want to, leading with help is a really awesome strategy. When you're thinking about the 2 or 3 components that need to be in place to effectively activate someone who hasn't engaged and thus missed their cervical cancer screening, like what are 2 or 3 things that have to be in place for everyone who's listening today?
So using the strategy that this plan is using, really the key is that you need somebody who's going to be on the phone who can open up that social care conversation, and at the same point in time has at their disposal like the ability, the technology, whatever it might be, the training, all of those elements to say, all right, whatever I hear, I'm going to be able to address in some form. I'm going to be able to work with the member in order to address these, right? So in order to really make this happen, somebody has to be confident in their ability to say, tell me about what you're worried about. Tell me about the challenges that you're facing, because I know I have the experience, I have the training, I have the technology, everything I need in order to really address these challenges right there.
Got it. You know, it strikes me, Sean, and put you on the spot, but I've gotten to know you and the team, Kesley, who's behind the scenes answering some questions. I'd love if people want to just pick your brain and learn a little bit more, not even necessarily about what you do as an organization as a solution set, but just how they could be better planning to do a lot of what you just outlined. I'd love them to get a chance to meet you. So if you're okay with this, what I'd like to do is put up a poll. Gene, get ready for this, where if people who want just an introductory call with Sean or the Benelynk team in general, depending on how many answers come in, I'll personally make an introduction and help you guys coordinate it, just so you could get some insights from this group and get to meet them, and no obligation to buy here, but just an opportunity to network and learn some things from some people that spend every day working on things like this. So why don't we put something like that up, Gene? And while you do that, I guess I'll turn it over to you. You're on mute again.
Sorry, I can't let you win this game. So Eric, hey, I want to go back into example mode again if I can. So to do that, I'm going to bring in someone who's been very patient through this episode, my friend Cherie Shortridge, who is the senior advisor at Healthmine. Now, Cherie, can you provide an example of a plan that refocused or is refocusing their strategy around member activation?
Absolutely. And thank you, Gene, for that kind intro. So one of the statements that Sean made, front of mind for the member, takes me back to my days at a mid-sized national health plan. We had about 135,000 members. And when I had the enrollment department, I had about 100 staff. Then again, a little later in life, I had the A&G staff, 100 staff again. And talking about empathy, we're sitting here in our offices, nice and comfy, and you have an aged and disabled membership that you're really dealing with. How many people are empathetic to that and really understand where they're coming from? And it's pretty easy to build these types of programs. There are programs out there that you can purchase anywhere from $800 up to $3,000, or you can implement something yourself that's just as simple as, what conditions do we want to focus on? So you have members who are hard of hearing, who have vision impairment, who have limited mobility or pain all the time. And just thinking about, regardless of what area you're in the plan, you're impacting that member's life. If you're sitting there in enrollment, every task you undertake is making sure that these members are able to get their health care when they need it. If you're in appeals and grievances, you're dealing with members who are not very happy, and they're probably disabled or aged or in pain and having issues. So some of the things we looked at was hearing. We brought the staff in. I worked with my team leads and my managers and had them facilitate each of the sessions so that they would feel that ownership and really buy in. And that kind of got the rest of the team in. We used earplugs. We had the safety glasses with the Vaseline on it to emulate glaucoma. Popcorn in your shoes. That's really uncomfortable to walk when you've got popcorn kernels in your shoes. And then background noise. And we would run scenarios. So we would act like you're calling into the plan. Okay, you need to get up and walk across the room and get a piece of paper so that you can write some things down. But we taped their joints so that their hands were stiff. We'd make them write with their left hand, or their right hand, whichever was non-dominant. I'm right-handed, so I go to the left. So that they could see what are some of the challenges. But before we jumped into that training, we set the table and we said, what is your perception of the aged population today, of the disabled population today? When you go to the store and that person is in front of you and they're taking longer and it's a little more challenging to do and things like that. And we really did get, okay, well, here, it drives me crazy. I don't want to take that time. By the end of the session, each staff member was asked that question again, and they're like, you know what? I can walk in their shoes. So when we're talking about the social determinants of health, we're talking about this population, creating that empathy within every operational department sets you up for creating the pristine member experience, for making sure that you're thinking outside the box when you're talking to a member. What could be their barriers? What do we need to do to help them overcome them?
Wow.
So, go ahead, Eric.
I love that. I mean, every organization should do that. That is what a great way of creating a culture of empathy and engagement, and just enable you to be more trustworthy and more engaging for all those members that are calling in. That's brilliant. A lot of hard work, I assume.
It was, but the staff really, having the staff engaged in delivering that training to each other also built that ownership and created empathy within the staff.
I love that. Cherie, I'm gonna keep you on the hot seat. So we heard a lot of good examples, that last one being super awesome. What are some things you've seen health plans do that maybe isn't as productive and they should avoid doing, that maybe is a common mistake amongst this audience?
So that fourth quarter push and also CAPS pushes. So when people are trying to reach out to their negative responders or improve their CAPS scores and the member experience, you may have 5 different departments calling the single member, and you're creating member abrasion. So in your effort to close those gaps, to create that really good experience, you're actually creating a negative experience. There's a plan that I worked with in the Northeast recently that they had lower response rates to their CAPS surveys this year than they've had historically. And I really suspect it's because so many people were calling. The members were tired. They were tired of answering the questions, tired of answering the surveys. So about finding that happy balance between enough outreach, making the member feel taken care of, and annoying them.
Interesting. That's a challenge. It strikes me, folks, and there's a few more questions here I know coming through the queue. We're going to hold a special session next week at 11 a.m. on Thursday. I know we're usually at 12 p.m. on the East Coast, 9 a.m. on the West Coast, a little bit earlier for everyone. But we're going to do actually a 2-way conversation for all of you next week. And we're going to address questions tied to social care and 5-star, achieving 5 stars. I know Cherie's going to be able to join us, and Sean, and maybe some others we're going to get. And it will be, don't come if you want to sit on your hands. This is going to be open Q&A. We're going to call it a fireside chat at 8 a.m. in the morning on the West Coast through Zoom. But you can get the gist of it. We're going to see if that could be a productive use of exchanging information for all of you and getting some of the answers to the questions you may have. So mark that down. Actually, Gene, let's do a poll on that too. I know we're a little poll heavy today, just so we can register people. We'll send you a calendar invite, I beg your pardon, if you want to come to this 11 a.m. on the 28th, if you want to join us for that. Let's shift over. I want to shift over to payer-provider collaboration and bring back Mallory Mueller and Network Health. Mallory, the collaboration with you guys and your providers, I know, is critical to be successful here. So can you talk a little bit about how you approach making partnerships with the vast providers in the market that you work with?
Yeah, I think one specific example that we have implemented really during the pandemic is really how do we work together versus parallel of one another. So we realize there's a lot of duplication going on between what the providers are doing for their patients and what the health plan is doing for their members, and really not a lot connecting the two. So we realized this during the pandemic and started to implement what we call our monthly grand rounds, or if you're from the clinical world like me, interdisciplinary care conferences. So you may be familiar with that term on the clinical side. So essentially we're bringing kind of a meeting of the minds, if you will, kind of all of the care team on the provider side, and then all of our care team on the health plan side. So we have our care managers, social workers, medical directors, pharmacy, and then any that want to attend from the provider system, and really coming together, looking at care plans, identifying what is the root cause for this member or patient. So looking at kind of an initial trigger of high ED utilizers. So members that have frequented the ED, coming together with the provider systems and coming up with a care plan that's really in tandem with both provider and payer.
So
As you
it sounds like almost you're almost doing these grand rounds with your providers. I mean, I know you didn't say those words per se, but that's what it sounds like.
Yes, absolutely. And you know, not surprising. We use the ED visits as our trigger of identifying members and patients. And pretty quickly we identified, you know, these members have underlying social care issues that are not being addressed by either the health plan or the provider. And focusing on some of those issues, we've been able to solve some of the medical problems. I think, you know, definitely seeing some behavioral health themes throughout some of these cases as well, and addressing that again is going to have some impact on the medical. So we are working right now to kind of identify some metrics of success and really expanding. So we started this with one of our provider systems. We have 9 major health systems where we have some value-based contracting, and so we're expanding it to 2 others this year, and I only see that continuing to grow. I think based on anecdotal feedback from both providers and you know, members, based on their feedback to their care managers, this has been a success.
I love it. I'm going to ask you a couple of quick follow-ups here from the audience. I know you answered one already when you typed it in, but I want to ask it again so everyone can hear the answer. What measures are you considering when contracting with new providers to help improve and drive your high star ratings?
Yeah, so again, I said at the beginning, I think to maintain a 5-star, I think you always have to be looking ahead. Always, what is for measurement year 2024? What's for measurement year 2025? And so we implemented in our value-based contracting where we are putting measures on somewhat of a display for our providers, where we're showing them their performance and talking about what interventions they should implement before they become a part of their regulatory payout. So really, again, working collaboratively versus kind of the stick method of saying, you know, you didn't do this and now it's going to impact your payout. We're trying to help them come up with interventions early.
As far as, is there anything about accounting or MLR or overall reporting that are nuanced that should be mentioned here? Or when you're talking about just how you're trying to drive quality improvement with your providers, anything around that?
I think leading with quality. So we have some thresholds that in order to, you know, meet any type of incentive payout, you have to get to a minimum star rating. So kind of leading with quality first in order to qualify for any sort of incentive has been kind of our philosophy.
Okay, David, I hope that got to your answer you're looking for. If not, you could ping me online. Go ahead, Gene.
Oh yeah, well, I'd like to pose the same question to Andre. Andre, if I can, how is UPMC Health Plan supporting their providers?
Yeah, in a real similar way, just making sure that, you know, they have access to timely data and information. When possible, if we can assist in like MedRec post-discharge. We have a great pharmacy team that can do a lot of outreach and actually do the MedRec, send it along to our provider groups and say, hey, these MedRecs are completed, you know, verify this information. And then, you know, they can document it all, submit claims on behalf of that, right? So doing things like that to assist. We have practice-based care managers in some of our practices, so that those care managers can do a lot of work related to maybe outreach around med adherence, and do a lot of that work and heavy lifting there. So we try to support them in any feasible way, because they have incentives and things tied to that we offer. And if they hit their incentives, that means we're doing well in our quality areas. So just providing as much support related to areas of focus that we have goes a long way.
I want to bring it back to Sean. I have a strategy question, Sean, but before I want to take a question from the audience that was out there. So we're going to come right back to the payer-provider collaboration strategy in a second. But is Benelynk aligning the social care challenges to health outcomes with folks with chronic illness? I think I know the answer to this, but I'll let you answer it.
Yeah, I mean, I think it's still early days for a lot of that, but yes, I mean, I think we know that there's a huge overlap between the population that has social risk factors and those that have chronic illnesses. So disproportionately, it's an opportunity to help that population by addressing social risk factors. I think one of the open questions is sort of like, do we as an industry start to understand the long-term impact on costs associated with addressing social risk factors? I think there's been some preliminary, work done around that, some preliminary studies, but I think we're still kind of early in terms of understanding the costs mitigation that comes from addressing social risk factors for folks with chronic illnesses. But I think intuitively, everybody kind of knows that it's there. So, but I think at the 30,000 foot level, we know that that's the folks that have chronic illnesses and social risk factors. There's a huge gray area that sits in the middle where those two start to bleed into each other. And supporting that population means that you need to have a holistic approach that really encompasses both.
So if I put your strategy consultant hat on now, and if you have any CEO or senior health plan leaders listening in right now, how should they be thinking about the evolution of the CMS requirements around equitable access and SDOH?
Yeah, that's appreciate the chance to answer that. I do want to just briefly circle back around to something that Andre said earlier, because I think it's important, and I probably should have mentioned it earlier. When we think about the health equity index now and the social risk factors, one thing that Andre mentioned that UPMC is thinking about is the populations that are not in the DSNP world, right, that are in your MA community world. One thing to just remember is that population is not necessarily static and defined. People can be brought into that population by helping somebody to enroll in the low income subsidy, or helping somebody to enroll in most of the Medicare savings programs, in particular the QI and SLIMB programs, which will then define them within that denominator of social risk factors, without necessarily moving them into a DSNP plan, because most DSNP plans are really only going to be for full duals or, the QIMBY MSP members. So it's a really interesting thought that Andre mentioned there that UPMC is wrestling with a little bit, is saying, hey, just bear in mind that even the denominator is somewhat malleable. There's opportunities to be bringing other folks into this denominator who have these same characteristics by getting them that benefit, getting somebody the low income subsidy, or getting somebody enrolled into one of the MSPs. So I just wanted to make sure I called that out, because I thought that's a very thoughtful area for UPMC to be thinking about and working on. But to answer your question, I think a lot of really what we're seeing these forward-looking plans doing is it's all about sort of laying the foundation. I mean, I think CMS and NCQA have clearly signaled that health equity and social care of the future, and that they're going to move fast. So when we look at things like something we haven't talked about today, the SNSE measurement, for instance, that, a lot of folks are starting to think about, right now it's asking about food security, housing stability, and transportation. But I think it's really noteworthy that from the very beginning, there's an action associated with, and how many of those individuals did you conduct an intervention within 30 days for, right? So again, as with everything else, I think that all the indications are the SNSE population is going to expand. probably the questions to be asked and the interventions to be offered will expand as well. But I think it's really, really important to see the way that they're pairing the identification of these challenges with the intervention right from the very beginning. So you identify what the challenge is, whether it's housing stability or food insecurity or transportation, and then how often are you able to sort of address that. So really that's the kind of foundational element: gather the information, conduct the intervention, that we're really seeing forward-looking plans, looking to say, all right, how can I do this? How can I identify even a wider population than what's defined currently who have these social needs, and then conduct the interventions. But a couple of models that we see out there, one is, bundling it into the HRA or other touch point where a need's identified, and then sending a referral over to an advocate to address this. One thing I would say under this model is timeliness is key, right? The duration between the identification of the challenge and the addressing that challenge, the quicker that can be done, the less time there is in between, the more likely that success is out there. But frankly, the model that we think is optimal is the one that we're partnering with Mallory and with Network Health on, is really saying, hey, let's conduct social care outreach. Let's treat this as its own initiative in and of itself. Let's gather this information through that human-to-human connection. And then let's, at the same point in time, pair that together with the intervention, so that really the common theme is that information gathering and advocacy are as close together as possible. So, I mean, there's a lot of really this desire for social care data that's out there. And I think that makes sense because everybody sort of sees this is what's coming. And I think what I would make that recommendation to those hypothetical CEOs is to say, thinking about how you can gather that information in a truly thoughtful manner that really centers the member experience. What does that mean? How can you be gathering that information? How can you be using it to produce a better overall experience for your members? How can you be using it to close other gaps like we talked about earlier? But also, most importantly, how can you be doing that in conjunction with a plan to address those challenges? And really, it should be a plan that the member is participating in building. They need to have that agency to say, you and I together are going to figure out how we can make your life better.
Great stuff. The questions are pouring in. I want to ask one about extended care health options, echoes, but what I'm going to do is let the group look at that question and ping me if we think we could address it. I'm going to continue on because I know we're tight on time. Mallory, I want to bring you back in. I want to anoint you a professor at University of Wisconsin's Business School, and you're now holding an important class to all these leaders listening in. How would you instruct them on building a program? Maybe provide the students with a step-by-step guide on how to build a program like this.
Sure. Yeah. Our provider quality improvement program, like I said, we just launched it this year. So definitely top of mind in terms of how we stood this up. I think, really the center of the program is really relying on that trusted relationship we have with our provider partners. I don't think it is standard for health plans to say, hey, providers, come and apply for this money that we're willing to give you if you decide that you want to engage in quality improvement activities. So really the core of our program here has been our trusted relationships between payer and provider. So I think, building on that, we really worked on developing what specific criteria do we want to put in place for providers to have some framework of what they're applying for. So really considering what measures are we trying to impact, how many members are going to be impacted, and then really how will this initiative tie to health equity and reducing disparities. I talked a little bit about how our metrics of success, the early indicators, are looking really positive. So that was another criteria of applying for this quality improvement fund, is that it had to be measurable successes, and that the provider was willing to provide the health plan with quarterly updates with, the caveat, if something's not on track, that we do expect some sort of improvement plan. I think we identified a governing body to kind of oversee this project work. And it was really important to us to have some external physicians as part of that review committee, so that we can get some outside physician leadership input on, how can we make the biggest impact on this population? So after we identified the criteria and the governing body, we really developed a policy and an application process. So really, again, putting the framework around how do we want this program to roll out. One of the key things about this program is we really wanted it to be quick and easy for the providers. We know how many things that we're asking them to document, and we did not want this application process to be a burden. So we developed a one-page application and a one-page template to provide quarterly updates that is really quick and easy for them. And again, the overarching goal of all this work is really to reduce health disparities and close gaps in care. So we really wanted to make sure that that was at the center of all of the criteria in the application process.
Wow. Okay, let me see if I got this. I was taking notes here, but for the group who was listening and maybe not taking as good a notes as I was. So first, it all starts with the collaboration with your providers. So that's number one. Two, you need to establish criteria in partnership with your providers based upon impact. How many members are going to be impacted? Is it tied to health equity and some of the business goals and clinical goals you're trying to achieve? Three, and in doing so, maybe I'm being a little bit redundant, but I feel it bears its own pillar here, is metrics of success need to be clearly defined for the project, like reducing gaps in care. Fourth is you've created a governing body to oversee this program, and you included in it external physicians, so you can get their perspective and probably make it a little bit less health plan bias, is my guess. And they're in charge of how to create an application process and policies that are going to enable this program to make the biggest impact.
Yes,
and
you
then
captured that, Eric. And I think
one more, because I thought this was one of the big ones. You have to make the application process, simplicity is the ultimate sophistication. It has to be quick and easy process, so there's not a big administrative burden, and it drives people who want to be part of it.
Yes, you captured it. Great. I think the governing body, I think most plans, if you're NCQA accredited, have a external quality management committee already established. And so that group has some external physician partners already on it, and they're focused on different quality initiatives. So this dovetails nicely into those agendas.
Wow, that is great. I mean, that's a detailed blueprint right there. So on that point, Cherie, I want to bring you back in. We just heard a great blueprint from Mallory. And for those of our listeners who need a clear path on how to get going, where do you suggest they start with building a program?
In 2 minutes.
In 2 minutes. Okay. Appeals grievances. Anything that's going wrong in your plan, if you want to hear the voice of the member, mine the data that you currently have, your appeals, your grievances. You're going to learn what members are not getting what they need, where you have gaps in your network, where you have gaps in your benefits, all of those things. Start there and build, and use all of the data that you have at your fingertips. I did this with a large plan in the Northeast, and we identified several areas where they improved the communication with the members, including adding language to their evidence of coverage and improving benefits for the next benefit year. All of those things are right there for you, and it absolutely is a source for the member. And I think we had a question about what about the members' families? As long as they are authorized representatives, you're going to get that information from them also. They're calling in. If somebody has a problem, you're going to know about it. This is not a population that tends to be quiet when there's an issue.
You're not wrong. You're not wrong, my friend. Excellent. Let me just say this, Cherie, excellent. Thank you so much. I thought Eric was going to chime in, but I get to talk. But we're nearing the top of the hour. So I just want to say a huge thank you to our incredible panel for the time and effort that they took to prepare and participate in today's episode. If you want more, we are having our special fireside chat. So join Eric, me, Sean, Cherie, and possibly some more guests if they're available next Thursday, 1 week from today, but at 11 a.m. Eastern time. I want to thank all of you for letting me learn on the job and co-moderate today. We hope you use these bright spots that we've unveiled today. They were shared to inspire your thinking, enhance your company's current approach, and to improving healthcare for all of us. We produce the show for you. And remember, to quote the great Eric Glazer, this is your bright spots.